Hey everybody, it's Kevin and it's Donna, and welcome to another episode of the Med List. We've got a great one here for you today. This was an interesting day, Donna. I've got a
Oh, yes.
big celebration with a big 3-year-old in the Walker household, so that took precedence of everything. But for the rest of the nation, there's something with the moon and the sun or something like that going on, I guess.
Yeah, just a little bit. There we go. I was out in the eclipse, 93% in Massachusetts.
Wow. Yeah, I have some coworkers and colleagues that are down in Texas, and the pictures just look absolutely incredible. I think
Yeah.
that one thing that's kind of fascinating, we think about just like a solar eclipse or a lunar eclipse, when we have two things kind of passing across each other. There's that moment of kind of interaction, and perfect for the med list, that moment of interaction, because when we have those discharges, people going into new facilities, kind of hitting that pivotal point of transition. That can be so difficult. And our guest we're going to have on today will help a lot of folks out to understand that transition and what's going to happen moving forward. So I will, without further ado, hit our button and we'll get going. All right. So I see him down there, and I could be wrong, but I feel like he may be mixturating right now. He could be doing some apothecary work, so I will add him to the screen.
Oh, hi, Kevin and Donna. I'm busy compounding right now. I'm gonna just put this aside so we can have a chat.
Oh man, alive!
Jaron, that's awesome.
Everybody knows. Don and I know.
I was actually making guacamole, so nothing's.
And he lives far enough away from me that him making guac is very rude. I mean, that'd be
Exactly. I'll bring the chips. Just tell me where I need to go.
Oh man.
I was just on a flight this morning too. I think I went the wrong way.
Yes, indeed. Well, thanks for inviting me on, you guys. I'm a big fan of both of you. You're both great. So happy to be here.
Ditto. So let me introduce you for just very briefly, Jaron. I'll let you speak a little bit more about you and what you've been doing and a little bit of your past. But Dr. Jaron Stout, he's a pharmacist and also a fellow of ASCP. So welcome with that, Jaron. And he's very involved as a consultant pharmacist. We're going to get into what exactly that is and what that means. But he's worked in both like industry type of consultant pharmacy and then also independently. And he is the owner of Collaborative Pharmacy Consulting and works independently for helping older adults really be improved in their health and really trying to just be an industry disruptor and thought leader. So I love that you put that right in on your LinkedIn, Jaron. And I just want to hear so much more about what you're doing, because it is bold to put that right under your name and you mean it when you say it. So I would love to hear more about what you are doing to help out older adults in long-term care and also in skilled nursing facilities.
Yes, thank you. I mean, I didn't originally I just had enough people tell me that was kind of what I was doing. And I was like, oh, you know what? You're right. It kind of is. So I just figured I'd just put it there. But yeah, I think my goal is to basically revamp the entire system of pharmacist consultants in nursing facilities. I think we're overdue for a bit of a reboot. Comic book movies these days are rebooting every 5 years. So I think we've been doing this 30 years. And based on the current data that says in the skilled nursing regulations, it says 66% of medication-related adverse events are preventable. So, and a consultant pharmacist has been a required service in nursing facilities for 3+ decades. So obviously there's a lot of work we need to do to make it so that we're actually preventing those adverse events and using our expertise. I think we've been relegated to sit in a corner and identify potential risks and then pass the buck to everybody else, when in reality, we're not utilizing our expertise and our training by assessing those risks. So basically, in a nutshell, I'm just trying to make it so that the consultant pharmacist is a service that is provided by the medical director. I think that would be the most ideal scenario. It provides us with a new platform to provide more billable services using CCMs, behavioral health integration, as well as incident to and annual wellness. It gives us opportunities to really bill for our time under a medical director's wing, which we don't have the ability to do that otherwise. It really opens the doors for us to generate revenue and spread our wings and prove our value.
I love it. Tell me this, Jaron, before we go too deep into some of the things that we need to change inside of these facilities that you've seen over the years, right? I'm not going to say how many years to anybody listening there. His hair looks beautifully silver.
I get a lot of compliments in nursing homes on this hair.
I love it.
Kevin, you have a hat on. I'm a little silver here too. What do you got going on?
It's still relatively brown. I've got
there you go. I know. I'm giving you.
Yeah, I'm looking forward to it though. The wisdom, that comes with it. Speaking of wisdom, give us some wisdom then, bud, when it comes to, there's a lot of folks that hear the word long-term care or skilled nursing, right? And they've encountered it potentially with a loved one, going into these settings, or as a clinician, they may have consulted with someone as they're discharging to one of those facilities. Someone is coming out into the community and maybe doing a transition for their medications or primary care, right? Those kind of things. How does someone typically encounter a gentleman like you doing these consulting services? How do they get into long-term care?
How does a pharmacist get into long-term care?
Patients. Like what's the
patient? Okay, yeah.
To get into long-term care. Yep.
So, usually it results in some sort of hospitalization. Something happened where they're demented and they got lost and they, wandered down the road and something happens and they get hurt and then they get put in the hospital. And then at that point, it's time for the clinicians to assess, well, is this person safe to send back home? Mm-hmm. Or do they have caretakers to manage their concerns? Or is it time to put them in a nursing facility where they can have 24/7 care and monitoring and people to take care of them and make sure they're safe and taken care of? So that's usually how it starts. It can be a COPD exacerbation. It can be a CHF exacerbation. They get to the hospital, and then that's where we have the opportunity to assess whether it's safe to send them back home. In many situations, they do get sent back home, but if it's not appropriate, then they'll slowly transition from that short-term post-acute stay into a long-term care stay. Does that answer your question?
Yeah, I think that, in general, when people think about what happens to a family member when they go into a rehab facility, like what is rehab? What is it when they're talking about assisted living? Like these become kind of confusing terminologies that we just mix together oftentimes, and in both medical and non-medical kind of cultural speak. And so was looking really for, like you're saying, an acute event of some sort, often leading to a hospitalization and the discharge saying that, hey, this individual is likely going to need an extra level of care, right?
Yeah.
Or you've seen what is called step down or step up, right? That someone is in a senior living facility, maybe then they transition to an assisted living facility where there's not as much that's being taken care of for them on a regular basis. And then they need even more when it comes to activities of daily living, when it comes to medication and laboratory services, and kind of the full ensuite of medical services, because either their care has kind of exponentially grown so that now they qualify for long-term care admittance, or their needs have pushed them into that setting. So just look over that for folks out there that you wouldn't necessarily see someone like Jaron or a consultant pharmacist in an assisted living facility as often as you would inside of a long-term care setting, like a skilled nursing facility. Anything to add to that, Donna?
Yeah, actually, I do. When don't I have something to add, right?
That's why we have a show, right?
Exactly. But I think it's also important that folks know that consultant pharmacists, and I think that this has grown a little bit too. I know that, Jaron, you're working more with the older adults, geriatrics, but also consultant pharmacists can also be in group homes too, and things like that. So even younger folks, depending upon what state people are living in and what the criteria is. So it's not always just older adults that might have a consultant pharmacist, but also consultant pharmacy, I think, is growing a little bit more too in regards to thinking about just medication reviews as well. And just don't be confused that, like a medication review or a pharmacy consultation, that is also sometimes coined as a consultant pharmacist, but we're talking in this particular segment about long-term care, but there is a lot of overlap with that terminology.
Yeah, and I'm glad you brought that up, Kevin, because I think about 10, 15 years ago, the people in long-term care are the people that you now see in assisted living. And the people that are in long-term care are the people that you used to see in hospitals. So, I mean, the need for higher acuity of care and oversight is growing monumentally. And if pharmacists aren't utilizing their training, it's going to have, we can make a massive impact and bridge that gap in care from provider to patient in this setting.
Yeah.
So.
Yeah, I think that it's such a, as we I slightly joked about prior to the show of the eclipse and the big transitions, there's multiple transitions, like Donna was saying, for, everything from pediatrics to geriatrics, from mental health status to dementia related kind of diagnoses. All of those elements can push someone into a long-term and or skilled nursing facility setting, right? Depending on acuity. But oftentimes there is a somewhat brutal transition we're just living home, everything's going just fine. All of a sudden, a huge number of medications are thrown on board, or things aren't working any longer, right? As we were hoping they would when it comes to maintenance. Now there's a big transition. We've got to go and live in a new facility with potentially, once again, more medications put on board. So it's not only the transition of, here's where I'm comfortable, this is what I'm used to, here's my routines, and now I've got to adjust to a brand new setting, which has physiologic and psychologic, impacts to the individual. There's also a massive transition when it comes to just how are we going to medically care for this individual, and what could have either precipitated from one disease state, like you're saying with COPD, becoming worse and someone needs to have this additional care and therapy, or a new diagnosis popping up. And now we've got to take care of that on top of everything else. So Donna, I'll transition to you just to talk about a little bit about those transitions and some of the things that both clinicians and patients can think about to be able to keep themselves safe and patients safe during that.
Yeah. So I know that being in the hospital, right, and having that type of care, again, like Jaron was saying, what happens? Is somebody going to be transitioned home or to short-term rehab, or even right to long-term care because their family just can no longer take care of this person? Jaron, you mentioned some major things such as COPD, heart failure, and some dementia issues, maybe even falls. Those are the big factors that I think land people in the hospital and then moving on to the next phase because they just can't care for themselves as much. So when you're talking about the meds being added on too, Kevin, and like just all of this addition happening, it's so profound to me when I see at the hospital what people are coming in on and then what is being looked at. So it might only be the acute issues that are being looked at and not some of the more chronic issues that somebody might have, or that might somehow contribute or might cause another reason for the person to be hospitalized. So even as we're teetering back and forth with that hospital back to home, back to hospital and readmissions, we're tackling multiple issues. And if we don't have pharmacists in all of these key areas, we're not catching a lot of these issues that could be brought on by medications. The other thing I wanted to just note, just from before, something else that Jaron had said, and maybe we can transition into, this might be getting a little bit ahead of ourselves, but thinking about that, you mentioned 66% of medication issues are preventable, I believe is the statistic that you had stated. But I've also been reading studies too and looking at studies. And I also see this in my own practice that only 40% of pharmacist recommendations are actually taken into account and changed, like those recommendations are put forth and moved forward by those that are practicing and can make those changes. Those are the prescribers. So when you say 66 are preventable and we have a lot of work to do, I always say only 40% of pharmacist recommendations are actually being changed and, accommodated, if you will. So yes, we as pharmacists have a lot of work to do because we're putting in that information, but we're still needing to communicate that and kind of quote unquote win that over a little bit. So I would love to kind of hear your balance about that.
Yeah.
We have all these meds that keep being added on. We're trying to take things off, but literally only 40% of the time is it. Yes, let's do this.
Yes. So I started my self-employment career on the backbone of collaborative practice agreements. And if you want to go into a facility and start making med changes, and the physician wants to give you the keys to the car to make these changes, you start to realize that you don't want to do just willy-nilly go in and make a bunch of med changes. You better look through the chart and assess what your findings are and identify an appropriate intervention. And, when you say 40% are not followed up on, I find that horrendous. And I would say mine are well over 90%. And that's because I do my research on the patient. And, I remember when I was on a rotation as a student, there was a physician who hated hearing from the pharmacist or the students because their complaint was, you guys never look at the patient. You just come to me with literature. You just come to me with guidelines. You don't actually look at the relevance to this patient. And I took that to heart, and I made it so that when I identify a potential intervention, I look for contraindications. I look to see if the relevance to that individual, see if it's appropriate. Mm-hmm. And I think 40%, and this is just my opinion, I think it's because we've historically been compliance checkers and we're just sending bogus recommendations of, hey, this person's on dual antiplatelet therapy. We should monitor for bleeding. Well, guess what? They're in a nursing home and the nurses are already monitoring for bleeding, whether or not we make that recommendation. That's creating unnecessary paperwork for the nursing staff. And it's basically undermining their, I'm sorry. It's just undermining their professional expertise. It's telling them to do stuff that they're already doing. But what if we assess the dual antiplatelet therapy? Mm-hmm. And I recently published a commentary piece in the Senior Care Pharmacist about this very matter. Rather than identifying that dual antiplatelet therapy is present, we should actually be assessing the appropriateness of dual antiplatelet therapy.
Right.
Because if it's for a stroke, that's a 21 to 90 day regimen. Identify what sometimes they'll put the stop date in the documentation, but not in the discharge orders. Sometimes the other way around. If you actually go digging through the documentation and identify appropriate courses of action, physicians are going to listen to you, they're going to respect you, and they're going to appreciate it. And that makes all the difference in the world, is showing that you not only know the regulations and the guidelines and the literature, but you know this patient because you looked at their hospital documentation. You didn't just do a blanket surface level review and then pass the buck for everyone else to figure out the rest.
Right.
I hope that answers your question.
No, it's fine. I agree with you. I have my students on rotation and that's what we're doing. We're digging through the records. And I always say, don't give me a recommendation unless you make certain that it is appropriate for the patient. I think though, Jaron, and it's just what I observe. I think where we function is different settings, and you have someone who's more like in the chronic phase, I'm assuming, of they're back from the hospital, for example, or they're just in from the hospital and you're making some of those recommendations and changes. I'm more in this acute setting and I'm looking at some other things and going, you know what, this is also a problem. And they're going, this is not the problem right now at hand. That's for somebody else. So sometimes I get that, even though we're trying to prevent other stuff from happening. I think that it depends upon the practice setting too. And I would love to see some of that disruption happening where we're all thinking about it every single encounter, whether person's in the hospital, in a SNF, in long-term care, wherever they are, seeing a specialist. Everyone should be having these conversations about, let's check all the meds. Let's be certain that they're appropriate.
Yeah. And, I'll take it a step further. If we're not doing that, we are 100% replaceable. Artificial intelligence is on our heels. And if we aren't doing stuff that utilizes our training and our expertise, we are absolutely replaceable. And, in the skilled nursing world, margins are really narrow. And, there are owners, there are administrators all over the country who look at the cost of what a consultant pharmacist is and thinks, wow, this is an unnecessary cost. Look at what they're giving me. They're telling my nursing staff to monitor for nausea. They're telling to monitor for bleeding. They're not doing anything that ChatGPT couldn't already do. And we're hinging our entire profession on 2 sentences of regulation that can be changed overnight if we get the right amount of administrators approach in this and make a move for a regulatory change that this is an unnecessary cost bogging down nursing facilities. And it's time for us to start making the impact. Otherwise, I wouldn't be surprised if something like that does happen.
There's an interesting quote and I use it quite often, by Charlie Munger, who was with Berkshire Hathaway, kind of the right-hand man of Warren Buffett. And he always talked about incentives, right? Incentives. You show me what the incentives are for an individual company, and I'll tell you what they do, right? And I'll tell you what they're going to do next. And I think it's fascinating in healthcare, trying to bring some of the clinicians and patients into this world with us a little bit deeper, understanding how is a skilled nursing facility regulated and what are the incentives inside of a skilled nursing facility in general, right? So some things to understand when you come into a skilled nursing facility, the number of recommendations that Donna and Jaron are going over right now, they're regulated by a body that leverage these codes called F tags. And inside of them, oftentimes there is a ton of controversy because what's focused on is, will the government or another governing agency tell someone what to look at and what to do, right? And so when you have someone in your job in any setting saying, these are going to be the next steps, I want you to check these boxes, guess what happens? Those are the boxes that get checked. And those are the ways that we go about reviewing individual profiles and statuses. And so, Jaron, really looking at that piece there of how do long-term care facilities work when it comes to someone coming with a new medication regimen. They've just been admitted to a skilled nursing facility. How long does it take until a pharmacist has reviewed those medications, given the recommendations for changes, alterations, et cetera, for the clinicians?
Okay, good question. So I think that's going to vary on, there's a few factors that go into that. So where in my practice, we look at every new admit within, the current statutory law. The Impact Act says every transition of care requires a drug regimen review within 72 hours, or it might be 48. Either way, so we do that. The funny thing about the Impact Act is it doesn't say that it has to be a pharmacist. Right. So I have been able to prove to my homes and show to my homes that having a pharmacist do it, there's a huge value in that. And so they're willing to pay that. So it really depends on who's willing to pay for it, who isn't, what the state laws are. But generally speaking, you should have a pharmacist review and identify any discrepancies within 24 to 72 hours.
So not required, like you're saying. Like it's the same thing with transition of care, right, Donna? If we're having someone discharged from a hospital, best practice as a pharmacist is reviewing all those medications and discharging and helping with that discharge plan. Not required, but best practice. Same thing with you, Jaron. Within within a couple of days of someone coming into the facility, having it reviewed by a drug expert, best practice. What's required though? What is current mandate that a pharmacist's eyes look at a chart?
Currently within the CMS regulations, I believe it says within, I'm going to say it's within 14 days. Okay. So, and that's just, so, that's a good question. So current mandate is once per month. So if a pharmacist is doing the bare minimum and they show up just once a month and look at charts and bam, they're done, there are going to be a bunch of people who admit and discharge before they come in for their monthly reviews. So there is potential that hundreds, thousands of people don't even get a pharmacist to look at their chart before they go home.
See, and that's the piece I really wanted to get to right there. Is just the fact that there are these big gaps. And I feel like when it comes to from a patient perspective, from a clinician perspective, here's the other piece of incentives. You've got clinicians, oftentimes a nurse practitioner working with an MD, reviewing an entire facility or multiple facilities, and they have a ton of patients. I mean, a massive load. And a lot of times these individuals are also working a hospital job or a primary care job. And this is another job they're doing as being a medical director. So they've got a lot on their plate. And I think what you and Donna were saying of like, what is the reason why we're only getting a 40% acceptance rate? You both make great points. I think another one of them that has to be highlighted is they're just short-staffed in time. I mean, just reading through those recs is brutal for individuals that are like, I just want my patients to survive, get the bare minimum done that's necessary to be able to take care of these individuals, and doing all these things in the background that may or may not be necessary. This is old thinking. I totally agree. I'm not saying this is right, but when it comes to medication optimization, that is something that has not been prioritized by the system. And
absolutely.
And so I think that's one piece, just to be able to highlight that. But the other one is this, Jaron, I wanted to ask you, because those gaps happen, and because you could have a patient totally missed, what ends up kind of moving the needle for you when there is a patient that's either having problems and not doing well, right? Or someone comes in, can a family member ask, like, I want my mom or dad or aunt or uncle or whoever it might be, I want their regimen to be reviewed by a pharmacist. Like, is that something that you have seen that pushed and better care been taken for a family member?
I think in the facilities where they're big fans of everything I'm trying to do, they will push it to families and say, hey, look, if you are worried about your family member, how about we have our pharmacist take a look and we can discuss with you his findings and yada, yada. So I think that is an aspect of it. There are, I would say, small numbers of people who say, hey, and maybe they don't say a pharmacist specifically, but they'll say, I want somebody to look at these meds and why are we on so many? And, my mom or my dad is drowsy all the time or confused, and I feel like these are contributing. So it is happening, but I wouldn't say nearly enough or nearly as pharmacist driven as it could or should be.
Got it. That's super helpful. And then on the clinician side, and not asking on Donna's side of the questions necessarily, but just asking from a clinician perspective, when it comes to you collaborating, right? When it comes to you collaborating with clinicians and you working with them and them wanting you to review charts in general, how has that relationship kind of evolved for you over time, Jaron? Because I guess what I'm trying to highlight for the audience here, so you guys get a good picture, is just because you get admitted into a facility, you have certain things that have to be done for you based on payment and based on guidelines and safety kind of components that are written by either state guidelines or federal guidelines we all have to adhere to. But best practice, you getting the highest quality care possible, is oftentimes a fully integrated collaborative team working together to take care of your loved one, right? So Jaron, I guess that's the piece I wanted to get to for you is, how have you taken a facility that really thought of, okay, we need to have somebody here to be able to check this box, to a facility that wanted to say, I want the best care for my patients, and drug optimization, med optimization is part of that.
And you want to know how my relationship with the providers has facilitated that? So
how have you helped that evolve?
Yeah. So once again, if we look at a traditional consultant pharmacist, The facility just, does a contract with the pharmacy to provide dispensing, provide products, and then, there's a pitch in, oh, and by the way, we're required to have a consultant. Could you send one? So they'll show up once a month. They'll do their minimum regulatory check. Oh, and by the way, here's your percentage of residents on an antipsychotic, and then bail out the door. I think what I'm trying to do is make it so that a medical director walks into a building and says, hey, how about I bring in a pharmacist who can educate patients on any med changes we're making, who can identify appropriate medication use. And the funny thing is, they can do that, and I don't even have to be the formal consultant for that facility. Now, that being said, I walk in and I work for this medical director and I start making an impact, and then the facility looks at this and says, wait a minute, why isn't this pharmacist the formal consultant for our facility? He's doing way more than our other consultant or what we've ever historically gotten from our consultant pharmacist. Mm-hmm. And so I'm trying by doing that, I'm starting to raise the bar of what is expected from a pharmacist. Like, why haven't we been attacking sliding scale inappropriately used in long-term care? According to the American Diabetes Association, for over a decade, it's inappropriate. Why are we not attacking that? Why are we, and the medical directors don't have time to address sliding scale. So when you do it, they see the value and they love it. And then the nursing staff is like, wow, I'm not checking 100 finger sticks per day anymore. This is phenomenal. I love this. This is great. So it's evolved by doing more than the bare minimum, unfortunately, at least where I live. I'm not going to say that everyone in the country is doing a poor job or insufficient or the bare minimum, but I do feel like we've gotten into a rut, into a rhythm, and it's time for us to wake up. And when you work closely with the physicians, and like I said earlier, I had like a 90%, keep in mind that sometimes there are an issue where I'll bring it to the medical director and then we'll discuss it and then I'll adjust it. So historically, a consultant pharmacist will just submit this report of their findings and then the medical director is a yes, no. But after discussing with them more about my findings and how I educated the resident and what I found and what I discussed, they'll say, oh, well, then how about we kind of alter it to this and this and this, because I brought them all this data. So medical directors and just practitioners in general see the value in that. I hope that answered your question.
That's fantastic. Yep.
So Jaron, I'm thinking about so I want to be a little bit of a disruptor too. And I think that it's really important that we measure some things and that we have things available for everybody on board so that we know that numbers, because that's what people are used to, right? People, yeah. Clinicians, prescribers, they're looking at numbers. They're looking at lab values. They're looking at any type of medical workup and the value of that. Why don't we have has blood scores? We were talking about anticoags. Why don't we have that right smack available on electronic forms? Why don't we have AC burden automatically calculated? Why don't we have this person is on 18 medicines, like the actual number of meds that the person is taking? What about frailty scores? What about METs? Thinking about even movement of the person in these facilities and how important that is in order to gain strength instead of let's deteriorate more kind of thought process. Yeah. So where are these numbers? What is we can't do this. If AI is right here and ready for us, why isn't AI doing this? Why aren't we already doing this right in the electronic records?
I've wondered the same thing. And the most common EHR in long-term care is point-click care. And for a decade, I've been asking a similar question. Like, for instance, they check their blood pressure and input it into the system before giving their blood pressure meds. And their blood pressure med will say, hold if blood pressure is below XY. But if it's below XY, it doesn't stop them from administering it. Like, simple stuff like this has not been implemented, and it absolutely needs to be in there. Like, if they input their blood pressure and it's too low, it should automatically exit out, say you cannot give them blood pressure medication, but it still allows them. Mm-hmm. So I do think that stuff is coming. And I mean, if you look
Not
at
soon enough.
yeah, I mean, the next 5 years we're undergoing a massive revamp, and stuff like that will be available, and there will be a lot more integrated systems.
Yeah. So, Jen, I think another really important one, you're talking about sliding scales, but I find that people do not understand diabetes. People that are caring for
Correct.
people in the facilities, they do not understand what carbs are. I don't think that they necessarily 100% understand what to do if there's a low, and then what comes next later. If someone's type 1 and they have a low and we get their blood sugar back up, if they eat a full meal, you got to give them insulin. And I think that some of these things are missing, unfortunately, in just the general practice. So, like you're saying, still give insulin if they're going to eat. Once their blood sugar is up, give a standard amount of insulin. Don't, slide
Right.
scale adjust,
Or,
but
if their
but
A1C is
like
at
you're
goal,
saying, just to
you
have
don't need
those
to worry.
safety factors in. Don't just say, "Oh, I'm not giving it." It should be like blinking. They're type 1.
Yes, and that's a good point, because I see them add meds when they're a type 1 all the time that is not appropriate for a type 1. So
Yeah,
yeah,
absolutely. So I just think like you're saying, there are so many factors that we can be talking about, and Kevin, I'm gonna take your side a little bit here, and just like, has blood scores teach us as um, clinicians as to the risk as to whether or not somebody has a really high risk of bleeding. So therefore, we might be a bit more cautious about what anticoagulants or how many anticoagulants somebody might be taking. So we're always balancing risk versus benefit, and that's what a lot of these scores that like I'm talking about and asking about, like, why aren't these alerts available? So just those checks and balances, like we're talking about risk versus benefit. And these change as our body changes. So you can imagine that someone who has been hospitalized, that's a change for somebody. It's not even just the fact that they've been on these medicines for maybe 10, 20 years for some, but now they've had even a more dramatic change of something acute that has now happened, that has put them into this other, world of where they live, some facility of some sort, and those changes that are made on the body.
yeah,
Love it.
absolutely.
What are the major things, Jaron? When we talked about has blood scores and we talked about frailty scores and all these things that are really trying to, basically what they're doing is they're trying to just give us a red flag that pops up and says, we want to look at this. Like, you should look at this and look at this patient a little more closely, right? When you go through and do your reviews across multiple facilities, thousands of patients, when you're doing your reviews, if we would just concentrate on the issues you find most often that you see across facilities, what would those be, Jaron? What are some of the things that you see in a medication regimen that folks could be educated on, both clinicians and patients, that these are really common problems you're coming across?
Yeah, obviously, it's funny. I had a theory on this, because the regulations I was talking about earlier, 66% of medication-related adverse events are preventable. Right after it says that, it goes on to say that the most common is diabetes-related, dropping too low because we're overtreating, and another common one is anticoagulation. So I started to emphasize those two alone, and I was blown away with the amount of issues I saw on anticoagulation. It's funny because I think we all thought that when the warfarin era was over, that it would really simplify anticoagulation, but that is absolutely not the case. When you start to look at what goes into dosing the anticoagulant, it depends on the indication, and the indication is what deciphers whether or not we're going to renal dose or not. A lot of people think renal dosing is across the board, but it is not. It depends on the indication. Then how long is treatment supposed to take place? Is it a chronic drug or a long-term or short-term? Is it for prophylaxis? And if they do have long-term clot risk, guess what? You're still going to adjust the dose after 6 months of treatment. Of course, you're supposed to reassess, but these are items that are always overlooked. And because I had that theory, I kind of dug deep into that with Cass Siebert and a couple other people at ASCP. We put a study together, and it's going to be published here in the near future. And I will say that I had a theory and I wanted to research this, and I was very surprised with what we found. So I think that there is a lot of work for pharmacists to do, because medications, especially in a population with vast polypharmacy present, we need to make sure that they're dosing them appropriately and for the right duration. The appropriate duration of treatment is widely overlooked.
Yes.
Looking at Forteo, bisphosphonates, anticoagulation. I mean, I could go on and on and on, and it's just this standard. You start a med and it just stays there. I've seen Mucinex stay on board for months, if not years. And
that's a lifelong med right there, Jaron.
Yeah, and it's the most worthless drug on the market, you know, and yet it's just everyone gets it and just keeps it. It's so frustrating. And seasonal allergies, when allergy season is over, get rid of the antihistamines. Like I could go on and on. People don't think about duration.
Me too. I did in my book, MedStrong.
Yes. I forgot about that.
Yeah, I do think that duration is so important, but also I think society is highly attuned to hearing something like phenylephrine was taken off the market, right? You're looking at things that are being pulled from the market based on them not having any utility in an individual. You mentioned some other ones that you've seen oftentimes in long-term care, not just because they might have a low efficacy, but because sometimes the issue is related to how long it's been taken no longer is beneficial, to an individual. How do you feel like when we're looking in long-term care and skilled nursing facilities, you mentioned, using artificial intelligence or just generalized algorithmic thinking, right, inside some of these systems? When you go about breaking down an entire facility, we're looking at hundreds of patients that in each individual facility, sometimes more. But when you're going through, you mentioned you took a focus on anticoagulants and diabetes. And I remember a number of consultants, what they would do is each month, like they would have almost like a theme, right, that they would go through, and they would review all the generalities of each individual, patient that came through, but also hyper focus on a certain drug class or a certain emphasis for disease state, whatever the case may be. When it comes to that, Jaron, like looking at these patients in that kind of manner, how have you gone about it?
That's a good question. So I have an opinion on this. So I have a quarterly rotation that I just kind of do every quarter. I'll switch my focus, and I have the same quarterly rotation that I do over and over and over. The part that I find unfortunate about this is we should have more time to dedicate to a chart review so that we don't have to have just a sole focus. And I think historically we undercharged for consultant services for so long, and then as a result, we put less effort into it. And as a result, people saw less value in it, and it just kind of compounded and snowballed. So now you have to have a focus. Otherwise, there's no way you can do a chart review in 8 minutes unless you have a focus. And so that is a good approach to have. Now, with the model that I'm working on, for instance, my quarterly rotation included 1 month where I do an emphasis on psychotropics, because that's always a big deal for nursing homes. Is what is their psychotropic utilization? I would identify off-label psychotropics, justify, write progress notes, discuss it with the providers, assess risk versus benefit for off-label use, yada yada yada. Now, with what I'm working on with collaboration in medical groups, now I'm identifying behavioral health integration, which is a Medicare program which allows us to bill for that time. So now I can remove behavioral health from my quarterly rotation and put more focus on deprescribing, put more focus on appropriate sliding scale use, etc. So by having these new opportunities come up and collaborating with medical groups as pharmacists,
nice,
actual pharmacists, providing consulting services, then it opens the doors and makes it so that we can actually have more time to perform more billable services and really spread our wings. So yes, it helps to have a focus, and the more we utilize physician collaboration and billable services, the more we can emphasize and grow that, so that every month we're doing an extensive med review as opposed to just a sole focus.
Nice.
Love it.
Jaron, I have one more question as on the provider side of things. Are you able to bill according to diagnosis. So, for example, say someone has edema and they're on medications that you find maybe gabapentin or amlodipine or something that is increasing their risk of edema, and you're making that adjustment. Can you actually bill for edema, or how would you bill that, or code, if you will, that particular one incidence that you're trying to reduce edema for this patient so they don't get into fluid overload and back into the hospital?
Great question. So you can do that as part of your monthly medication review. Just as a simple example, you identify that the charting documents frequent pitting edema, excessive fluid retention, yada, yada. You identify 2, maybe 3 meds that are present, amlodipine being one, maybe oxybutynin is a potential contributor, etc. You identify that during your monthly medication review. Then I am able to turn that. Now, historically, if a consultant pharmacist did their job, they would submit this report to the medical director, and then the medical director looks at this sheet and says, "Oh, I'm going to go generate a visit out of this." But if we work for the medical director, we don't have to bog them down, and they can keep doing their expertise elsewhere. We can perform that visit for them. Now we can go educate the patient. Hey, I notice you have problems with fluid retention. Here's some medications that I identified are contributing to your excessive edema. And here's some things we can do to resolve that. And by the way, by getting rid of this, we're also going to resolve other problems. Like if you're on oxybutynin, we'll resolve potential cognitive decline. We'll find out if you really need the medication, what kind of impact it's making, if we need to replace it with something else, or if we don't need anything anymore at all. That education for the patients and performing that for the physicians, so that they aren't stretched as thin anymore, it goes a long way. So yes, you can bill for the time, but it's 2 separate tasks. And when you work for the medical director, that is an option. You can perform incident 2 visits on their behalf under their NPI. And right now, due to the public health emergency waivers that are still in place, even though the public health emergency has ended, the waivers are still in place through the end of the year. And that means you can do general supervision, meaning historically we had to be in the building at the same time for that visit to take place. Right now, that is not the case. And there is efforts in place, not only from my coalition, but from other professional organizations to make that a permanent change in nursing facilities. Because it doesn't make sense to make general supervision the requirement in nursing facilities as opposed to other settings. So,
wow. Yeah, everyone listening, we've covered a huge array of topics today. Some major takeaways, though, Jaron, that you'd like to leave the audience with, buddy. Please lead us away with those.
Yeah, the future is almost here, and I may be an extremist in my opinion, but I feel like with what pharmacists currently do, if we don't make some significant changes and start using our training, we are and will be replaced. I think a vast number of jobs will be replaceable in the very near future, and we have to do our part to show that we should not be replaced for as long as possible. So the future is here. It's time to use our training. It's time to spread our wings. It's time to upgrade and become the next level pharmacist, be a pharmacist 2.0, which me and Kevin will be launching here shortly. And also, if we've been fighting for provider status for decades with no movement. And in my coalition's interactions with CMS, they ask us, why do you want provider status? We've given you all these other billable opportunities and you haven't used any of them. MTM, CCM, BHI, Incident 2, Annual Wellness. You don't collaborate with physicians. You don't do any of the things that we've given you. Why on earth do you want us to give you more when you haven't even utilized the tools that we've given you? And by the way, provider status is actually quite complicated. Billing for your time comes with an entire world of understanding that we currently do not have. And Incident 2 will bridge our knowledge gap to get there eventually. Mm-hmm. These are the tools we have to utilize to not only stay afloat as professionals, to stay relevant, but also help us bridge the gap to the future of our profession.
I love it. Yeah, no, that's fantastic. I think the interesting thing for patients to get a better understanding of is really the advocacy component doesn't stop at home, doesn't stop in the hospital. When someone transitions, I mean, my good colleague over here is advocating for her family members all the time, you know, and I think that is a beautiful thing to recognize that if you're in an assisted living facility, if the family member is in a long-term care setting or a SNF, when they're getting to see, you know, brilliant folks like Jaron there, it's so important to be able to get the best care for our family members and loved ones. And part of that is saying, how are you caring for my family member and loved one, and who's involved in that care, right? I think that oftentimes we under-recognize how valuable the patient and the family voices are to be able to move the needle for their family members. And it's interesting that will get more people in the door that are able to help your family member live a better, healthier life and have a higher quality of life during that, you know, pivotal stage. Donna, any closing words for us?
Yeah, I just think that, you know, there's much to be looked at and changed and improved for all of us, right? For both pharmacists, the prescribers, and especially the patients. So I do think that, you know, having these conversations is so important, and to move that needle and make people aware and have it be everyone who's aware. I love that we bridge these conversations between patients and providers. So I think that we need to continue these conversations no matter where our patients land.
Amen.
Yeah.
Amen.
Well said.
Awesome.
And just FYI, I'm currently building a webinar with Thea Blystone, and we'll hopefully have something for ASCP membership to take advantage of, so that we can start getting more pharmacists aware and start doing all these services.
Awesome. No, that's so helpful. Well, thanks everybody for joining us. Please like, listen, subscribe, LinkedIn, YouTube, Facebook, Apple Podcasts, Spotify. So those are us. And we sure look forward to seeing you again here sometime soon. Have a great rest of the day. And hopefully
thank you.
Good.